Good evening. My name is Melissa Davis, and I am a Senior Nurse Manager here at Desert Regional Healthcare Alliance, and I'm here to discuss the care management of cervical cancer in older women. Here at DRHA, we've recruited 2 new gyn-oncology specialized surgeons, and we anticipate an increase in this population, especially in the more complicated cervical cancer cases. So I've brought together today an interprofessional team that will be involved in coordinating the care of this population. The learning outcomes of this presentation are, after this presentation, team members will be able to verbalize and increase understanding of the cervical cancer disease process. This includes the pathophysiology, symptoms, and progression of the disease. They will be able to verbalize critical assessment findings, including physical, psychosocial, lab, and other diagnostic findings. And finally, you'll be able to verbalize the understanding of care management of this population, including health promotion goals. This includes different treatment modalities and outcomes. A population overview. Cervical cancer is the second most common cancer in American women. This is despite a 50% reduction in incidence and mortality since 1975. And this reduction is attributed to improved screening programs and development of an HPV vaccine. Despite this, it's estimated that in 2015, over 4,000 women will die, and almost 13,000 cases will be newly diagnosed in the United States alone. We often hear about cervical cancer in young women in the media. However, accounting for the high incidence of women with hysterectomies, it's still an 18.6 per 100,000 women over the age of 65 that will be diagnosed with cervical cancer. And there's a disparity in outcomes for women over 65. These women are often more likely to have morbidity and or die from their disease, and this may be due to other functional deficits, and just being older can make it more difficult to recover from treatment. So goals of care. The primary goal in any cancer treatment is in curing the patient of the cancer. In early and advanced cervical cancer, cure is possible. 5-year survival rates are 80% for stage 1B, and it drops to a 30% 5-year survival for stage 3 disease. However, once cervical cancer has reached stage 4, it is no longer considered curable, and treatment is palliative. Patients may also suffer from significant side effects due to not only the disease itself, but from the treatments, and these can be managed by different pharmacologic or complementary therapies that we'll discuss more later. And the goal of palliative care is to prevent and relieve symptoms related to disease and treatments. And this care should always align to the patient's own goals and values. And it's very important to remember that palliative care is not hospice care. Palliative care is about bringing together resources to improve the quality of life for patients and to help manage their symptoms. Promoting health and reducing risks. Focus needs to be on prevention and early detection. Pap smears are one of the most important factors for early detection and prevention of cervical cancer. Patients diagnosed in stage 1 have a 90% 5-year survival rate. So it's really important that women are getting screened, and it increases their chances of survival immensely. It's estimated, though, that 12 to 29% of women don't receive screenings per recommended guidelines. And these guidelines depend upon age and histories, so they can change. So it's really important that women are getting the recommendations of their provider and are getting recommended follow-up. Cervical cancer is most diagnosed in women who have failed to follow screening guidelines, and they tend to have had a large gap in screening. Often older women don't believe themselves to be at risk, yet there's actually an emergence of a second peak of HPV infection in this population, often because of divorce, changes in lifestyle. Women tend to have new partners, this sort of thing that can lead to an increase in this infection. And after the presentation later on, we'll go over ways to support the health and wellness during treatment. The focus after diagnosis is on supportive care and reduction of side effects and symptoms. So pathophysiology, many cancers, including cervical cancer, are caused due to DNA abnormalities. There are different genes that regulate cell growth. Oncogenes direct cells to grow and divide, whereas some genes, like tumor suppressor genes, tell cells to stop growing or die. And so when these genes fail to regulate appropriately, cancers can form. So in most cervical cancers, it's believed that HPV produces two proteins, E6 and E7, and these proteins will turn off the tumor suppressor genes that tell the cells to stop growing, and this results in an overproliferation of the cervical lining and thus a carcinoma. It's important to note that cervical cancer without HPV infection is virtually non-existent. And the progression to cancer occurs in 4 stages. First, there's an initial infection, and then a persisting infection. The clearance doesn't occur. And many HPV strains and in many infections, the immune system can clear the infection all on its own and with no intervention. So sometimes that's not able to happen and the infection persists, and this goes to the next step, which is a development of precancer cells, which is not cancer, but then finally, left untreated, it may result in an invasion of cervical cancer. And it's important to know too that this isn't a linear process. Sometimes the progress becomes latent, it can regress, and the exact progression to a carcinoma isn't well understood, and it can happen with some strains are more aggressive, it can happen in a year, whereas other strains, it can take decades for it to actually advance to cervical cancer. A patient could have had an HPV infection that they didn't know about for years and years and years, and they don't know until they develop cervical cancer. Typical symptoms. So the symptoms depend oftentimes upon staging. Stage 1 cervical cancer is cancers that are isolated just to the cervix. This is often asymptomatic. Excuse me. Stage 2 and 3, these cancers have spread beyond the cervix and into surrounding structures. And finally, in stage 4, this cancer has invaded the bladder and a rectum and may have grown completely out of the pelvis and into other areas of the body. So early disease is often asymptomatic. Women will have no idea they have it. Again, another reason why screenings are so important. However, as the disease advances, women could experience, not always, vaginal bleeding, especially after intercourse and or menopause. Vaginal bleeding at these times is never normal and should always be checked out. Discharge that might be foul smelling. And this is just due to, as the cancer grows, creating cell death. It can create a foul-smelling odor. And then pain. Pain after intercourse or without, any abnormal pelvic abdominal pain could be a sign. And it's important to note that none of these are specific to cervical cancer. These could point to a completely benign condition, but they should be checked out. This leads us to other critical assessment findings. So when a woman presents with cervical cancer, typically you'll find in her history that a lack of follow-up and poor history of regular screenings, a positive HPV screen, an advanced disease. Other symptoms that you can see are leg edema. This is as the tumor spread, it can compress vessels, invade the lymph system that affects drainage, creating pooling and swelling in the legs. Urologic complications, as tumors spread, it can block the ureters, create fistulas, hydronephrosis, infection, renal failure. So women may be experiencing problems urinating, difficulty peeing, painful peeing, that sort of thing. And then more pain and bleeding. The bleeding may increase, the pain may increase. Cervical cancer is often described as being very painful as it progresses because it invades nervous tissue. And then don't forget to think about the psychosocial assessment of these patients. Cancer can create a variety of emotional reactions. Including anxiety, depression, and those definitely need to be assessed and treated. There could be an increase of nausea, pain, and those should be referred to treatment. What is their support system? A lack of support system is linked to increased incidence of depression. Spiritual beliefs should be assessed. Religious patients tend to have lower levels of anxiety. However, it can also give you a window into how, if the disease progresses, how they will want treatment. Often, the more religious people are, they tend to gravitate towards extreme end-of-life measures and may not want to be a do not resuscitate, for instance. And all of these affect quality of life, not just the physical symptoms, but the psychosocial as well. Lab and diagnostic data. As we discussed before, screenings, including the Pap smear. Pap smears are cytology-based. However, they're subjective and they have low specificity. So while it's a simple swab and it can detect abnormalities, it's been found that up to 30% of normal Pap smears actually, those women do have cervical cancer and it was missed. And then important to note too is that women over 65 are recommended to stop if they've had normal screens in the last 10 years. So some women, once they hit 65, may assume that they are okay to not get any more screens. However, if they haven't been receiving their screens, then they would need to continue to get them until cleared by their physician. HPV testing, this has been done in conjunction with Pap smears because it's 90% sensitive, and it helps genotype the HPV strain. There's many strains of HPV. Some progress to cervical cancer, others don't. So it's important to get this in conjunction with the Pap smear because it increases the chance of diagnosis and it aids in the decisions of what kind of treatments. If a Pap smear or HPV test come back positive, women may be referred to colposcopy or a cone biopsy. This is an invasive procedure, usually involves anesthetic. It is outpatient. Women will be sedated, some cells will be taken, and they will sent for diagnostic testing. And the biopsy will be able to tell for definitively if it is cancer cells and at what stage the cancer is. And also to what type of carcinoma are we looking at. Is it squamous cell, that sort of thing, which can depend upon treatment as well. Finally, imaging studies, MRIs, CT, PET scans, these are diagnostic and prognostic. So from these scans we can see the progression of the disease as well as what structures is invaded, has there been metastases. We can also tell whether or not treatments have been effective. Are they shrinking tumors, that sort of thing. So holistic therapeutics. So according to the gynec physicians, primary treatment usually involves radiation, surgery, and chemotherapy. Depending upon stage of illness, treatment goals, age of patient, and other factors, radiation and chemo may be chosen over surgery or done before surgery, or surgery may be first line of treatment. So it just depends, and that will be decided on between the patient and the physician. Different pharmacological therapies also are available to help treat different symptoms of cervical cancer disease itself, as well as the side effects from surgery, radiation, and chemo. Patients can experience nausea, vomiting, pain, depression, all the symptoms we've discussed before. So it's important that the team work together, pharmacists, palliative care specialists, and the physicians and nursing to look at what narcotics, steroids, antiemetics, benzodiazepines, antidepressants, as well as other medications that may be appropriate to treat these patients. Complementary therapies are also been shown to be very helpful in cancer care. According to Susie Bohnkamp, a clinical nurse specialist, many of these she's seen herself be extremely effective. Some of the ones that she finds the most helpful tend to be pet therapy. Pet therapy studies show decreases stress, anxiety, pain, depression, even with short visits. Sometimes just as little as 15 minutes, just petting the therapy dog can be very effective for patients. Aromatherapy has been successful in addressing anxiety, nausea, stress. It can promote relaxation and sleep. And acupuncture has been shown to relieve many symptoms related to cancer disease and treatment, and can be available for patients to seek out. Collaborative outcomes. So it's always important that we are focusing on the individual and what does the patient value in their quality of life, in their treatment, what are their goals. Cancer care is challenging, especially in older women. As we discussed, they have a higher rates of morbidity and mortality, so approaching individually, often older women may choose less invasive procedures. They may be more appropriate, not just due to goals of care, but studies have shown that older women may not fare as well with surgical interventions. So that needs to be discussed between the physicians and the patient. There needs to be a focus on improving the quality of life through symptom management and support. The American Society of Clinical Oncology has begun to recommend palliative care from diagnosis as the standard of cancer care. Palliative care focuses on an interdisciplinary team, nurses, physicians, social workers, pharmacy, among others, to provide evidence-based symptom management and to promote shared decision-making with patients, not just about their treatments and management of symptoms, but also once we reach needing to make end-of-life decisions. So an interdisciplinary team, like I've said, is very necessary for these patients. Studies have found that physical and psychosocial issues and concerns continue. One study showed issues continuing even 15 years post-treatment with lymphedema, sexual dysfunction, depression, anxiety, urinary issues, depending upon the advancement of the disease. So continued need for resources and support. It's important that we set up these resources early with these patients and so they know where they can turn as they continue, because it could be a lifelong journey with these patients. So in conclusion, it's important to realize that cervical cancer is a unique diagnosis. It's considered preventable. It's asymptomatic. Women often don't know they have it until it's very advanced. It continues to occur in pretty high numbers, and it affects women across the spectrum. So while we hear about it often in young women, it often affects older women and can be more devastating in older women. So nurses must work with an interdisciplinary team to help eliminate disparities, improve the access to care, access to treatment, help patients know their resources, know where their support is, and continue to support patients through this difficult diagnosis. So I want to thank you for your time and listening to my presentation. I've completed a fast fact sheet with some key points from this presentation that you are welcome to pick up and look at on your way out. If you do have questions, I'm happy to answer them, and please enjoy the rest of your evening. Thank you.